final talk for this session is my good friend Lana Sundac, who is a dual-trained clinical microbiologist in infectious disease position at the PA. She keeps us all on the straight and narrow, speaking as a transplant physician. And she's going to speak to us about perfusion culture and fluid-related microbiology and infections because I made her do this talk. Thank you.
So this is the topic that I was assigned by my dear co-organisers today, but it's been a really interesting deep dive. Now, we've already heard from our fantastic speakers in this session that organ preservation is critical to the success of transplantation. And already the preservation techniques have been outlined in that static cold storage as being the standard of care for the last 5 decades, and that dynamic techniques like hypothermic machine perfusion and normothermic machine perfusion have really evolved in order to try and utilise marginal donors. Static cold storage, because I'm not a surgeon, I had to create my pictures on OpenAI. I think they look pretty cute, but I'm not sure about the scale. So basically the organ's flushed, as Pram said, and then sits in a preservation fluid solution that's very cold. Compared to hypothermic machine perfusion, where the organ is initially flushed and then attached to the perfusion circuit. And the perfusate is cold, but it's continuously circulated through the organ. And this is a picture of the Lyport machine that we have at the PA. In liver transplantation, we've heard from Pram about the organox, and this is what happens when you send a physician into a theatre. You let me in, I become a fangirl and I take photos, but Yadska knows that I'm using this with permission today. So this maintains full metabolic activity. It's warm and it's packed red cells going through with some antibiotic. It varies which antibiotics go through. There's some outrageous things overseas. Cephazolin is, it makes me proud because it could be inopenin and metronidazole, for example, in some of the studies that I read. So the contamination preservation fluid as a potential vector for donor-derived infections has been recognised for decades, but really the formal study on this topic took off in the early 2000s and through to the 2010s, I guess for a couple of reasons. Things that gained momentum were increasing recognition of the importance of donor-derived infections, but also some significant advances in microbiology techniques, including automated blood culture systems, which have been repurposed to culture a variety of fluids, including preservation fluid. So the techniques that have been used in the studies that I'm going to discuss include standard culture, enrichment culture, and automated blood culture systems. With standard culture, preservation fluids are directly plated onto solid media, onto agar. And this is a great, simple, widely available method where you can grow a number of different organisms, but it's not optimal for low burden infections or low burden organisms and those that are slow to grow, and does have some delay in culture as one of the slower methods. Enrichment culture is a bit more time consuming in that you've got an additional step where you put the preservation fluid into a nutrient-rich broth first and then plate it from there onto agar. It's great at increasing the yield of pathogens or organisms that are there in low number. Unfortunately, it can increase the yield of contaminants as well. And then lastly, the high sensitivity technique, and the one that's most rapid from the time to detection, is the use of automated blood culture systems. Now, these are sophisticated, expensive instruments that we have in our diagnostic laboratories today. You've all seen the blood cultures on the wards, and any sort of fluid can be put into these and then incubated in the machine, which is a continuous monitor and incubator, usually for about 5 days. And it flags positive, and then a scientist takes over and processes these cultures by a manual method. But even before we get to the culturing step, there are a number of factors that really influence the yield of a culture, which we in microbiology call the pre-analytical phase. This is how much fluid was collected, at what point in time. Was it at the time of procurement? Was it on back table prep? Was it just before implantation? Were there any antibiotics in the preservation fluid to begin with? Because they can inhibit the growth of a range of organisms. So the first systematic review and meta-analysis that really pulled together the available evidence on this topic was published by Oriel and colleagues in 2018. They analysed 17 studies. They were all observational, all single centre, and all by 4 were retrospective in nature. And as you can see in the bar graph on the right, despite the fact that they had almost 4,000 preservation fluids analysed as part of this meta-analysis, the vast majority were from abdominal organ transplants. What they found was that the incidence of positive preservation fluid cultures was about 35% overall, but There was a marked difference when you looked at retrospective versus prospective studies, with the prospective studies showing growth in over 80% of samples. This is likely due to the much more systematic and complete culture protocols that were used for the prospective studies compared to retrospective, where they just made do with what they had. The sorts of organisms that we've seen across the studies include most commonly commensal flora, so coagulase negative staphylococci, virulent streptococci, for example. But there are also organisms considered more pathogenic that have grown, such as Staphylococcus aureus, gram-negative bacilli, beta-hemolytic streptococci, and Candida species. The meta-analysis that I mentioned earlier could use 11 studies for looking at what sort of pathogens were grown. Overall, the incidence of pathogenic organisms was about 13% compared to 19% growing only commensal flora. Once again, that difference in prospective versus retrospective studies continued through the data. What they found when they drilled down into perfusion-related infection rates was that overall they were relatively low at 4% across 16 studies that evaluated for this. But when a pathogenic organism was cultured from the perfusion preservation fluid, the rate of infection was 10%, whereas when commensal organisms were cultured from the preservation fluid, there were no PF-related infections. The mortality rate, however, in infected recipients was very high at 35%. Now, this data is obviously quite sobering, but it's important to remember the limitation of this is that it was based on the available studies, which were all mostly retrospective in nature. What about giving preemptive antibiotic therapy to patients when preservation fluids are contaminated? There's no uniform definition in the literature, but really what PET involves is looking at what organism is cultured in the preservation fluid and giving a tailored antibiotics to a recipient who has no clinical signs of active infection at the time. Some studies have shown that there's a higher risk of PF-related infections among untreated recipients in some studies. In the meta-analysis that I've already mentioned, they found that this difference was quite small. In the pathogenic organism group was about 2% in patients, a 2% higher rate of infection in patients who were untreated compared to those who were treated. But there was no difference at all in infection rates in those with commensal organisms. To further explore this, the same group in Spain conducted a prospective multi-centre cohort study in 7 transplant centres across Spain. They looked at culture-positive preservation fluid in 622 organs. More than half of these were kidneys. They found quite a high rate of contamination, although low-risk organisms predominated. And this was really aligned with previous prospective study findings. 20% of patients received PET when cultures were positive. The overall rate of infections was actually quite low. Only 1.3% of recipients that had a positive culture had a PF-related infection. But what they did find was that in the subgroup where their preservation fluid had grown a pathogenic organism, if they didn't receive PET, the PF-related infection rate was higher at 8.5%. They were not able to calculate any sort of odds ratio because there were no infection events in the patients who received PET. On the other hand, this study from a group in Italy found that there was no difference in administration in patients receiving PET versus those who were not treated in terms of contamination and association with subsequent PF-related infection. They looked at kidney transplants only, and they had 290 samples. The positivity rate in this retrospective study was similar to previous study findings, and low-risk organisms were found at higher rates than high-risk organisms. They looked at the difference with PET. They divided the patients into 3 groups. The first group had a bacteria that was resistant to their standard perioperative antibiotic prophylaxis, and this group was given PET. The second group had an organism cultured from the PF that was sensitive to the perioperative antibiotic prophylaxis, and therefore no additional antibiotics were given. And then the last group had a bacteria isolated that was resistant to the standard perioperative antibiotic prophylaxis, but they were not given PET. And they found no difference among the 3 groups. But there's a major limitation to this study in that everyone received a really long course of perioperative antibiotic prophylaxis, outrageously 9 or more days post-transplant, which we just don't see in our setting. In a similar vein, a US study conducted in Chicago, also in kidney recipients, the retrospective cohort study, found that there were high rates of contamination, mostly with low risk organisms, but they found no infections where the PF organism matched the organism found in the recipient. Despite this, about two-thirds of patients still got some preemptive therapy, but there was no outcome benefit. To grow the body of work, a couple of large studies came out of China at the turn of the last decade. With more than 1,000 preservation fluid samples from deceased kidney donors, this group found a really high rate of contamination of the preservation fluid. The thing that was really concerning was that over a quarter of these organisms were the escape pathogens. Thank you, OpenAI, for also creating this little picture. Lots of tweaking, lots of tweaking. A microbiologist couldn't let Enterococcus faecium look like staph. Had to be a chain. The escape pathogens have been grouped because of their virulence and the recognition of rising antimicrobial resistance in this group. So it was of some concern that over a quarter of positive samples were due to these pathogens. Despite that, still quite a low rate of infection, with PF-related infections only about 2.9%. And most of these were linked to the high-risk pathogens, Candida and Escape. And they did a number of analyses, and the only finding on multivariate analysis was that escape contamination was an independent risk factor for PF-related infection. In this study, the interesting finding was that the infection rates were a lot higher than in some of the previous studies. So if you look at bloodstream infections and graft site infections, they're in the order of about 10% in patients who had a contaminated preservation fluid compared to those that had sterile fluid. And these figures were even higher still, with larger difference, when the organisms cultured were escape pathogens or Candida. But why don't we treat everyone who has a positive preservation fluid culture? Well, it's tricky. We've got high transplant volumes in most resource settings around the world, and even a small change in practice could have potentially major epidemiologic impact. Even at our centre alone, we do about 200 kidney transplants a year. We're wishing out antibiotics, additional antibiotics for every one of those. The microbiology of our hospital setting might change. There's also some data to suggest that PET, based on PF cultures, can actually be linked to increased ESBL carriage in recipients. There's data from these observational studies that treating the low-risk contaminants probably is of no clinical benefit and therefore just risks antibiotic overuse. And we have to acknowledge the evidence gap that we really don't have any randomized control trials at this stage to define the impact of contaminated preservation fluids and to guide treatment, let alone by pathogen or organ type. And prolonged use of antibiotics in these patients puts them at increased risk of resistance, C. difficile infection, and toxicity. There are a number of challenges that remain. Because we only have observational data to date, the role of PF culture remains unclear and still heavily debated. While PF positivity is common, it is often due to low-risk contaminants. Clinical significance of positive PF cultures is still uncertain. We think that potentially high-risk pathogens may increase the risk of infections and their severity. However, without good RCT-based data, we don't have any guidelines or protocols to actually define what we should be doing about these results. And therefore, at this stage, even though on a case-by-case basis may be acceptable to do these cultures and clinically helpful, especially, for example, in the case of iatrogenic bowel perforation, routine screening at this point lacks proven utility and just carries a risk of antibiotic overuse and emergence of resistance. But what do we know about machine perfusion and contamination in that setting of the perfusion fluids? Well, this is the first case report of a serious infection in the liver transplant recipient where the organ was preserved using hope, which Fran so nicely described for us earlier. This was a 70-year-old man who had cirrhosis secondary to Hep C and also had a hepatocellular carcinoma. This was done in an Italian hospital where their protocol was actually to have a period of time on normostatic perfusion followed by hope, and he had perfusion cultures just before implantation of the organ, and they eventually grew an ESBL producing E. coli. Post-op day 3, the patient had signs of active infection, fever, high white cell count, high CRP, and eventually was bacteremic with the same organism as was growing in the preservation fluid based on the antibiogram. He received carbapenem therapy very early, knowing that it was an ESBL E. coli. Despite this, he had persistent bloodstream infection. And later abdominal imaging showed that he had a perihepatic collection, which is eventually drained and grew the same organism, same antibiogram anyway, from the preservation fluid. Unfortunately, whole genome sequencing wasn't done on any of these to confirm that they were, in fact, identical. Patient did well overall. But I guess it raises the point that we don't put antibiotics in fluids generally. There could still be an environment that would allow proliferation of aerobic pathogens. And the fact that this patient got very sick despite early targeted therapy suggests that there may have been a high organism burden or inoculum effect. The same group, led by Andrea Lombardi and her team, then went on to conduct a 5-year retrospective study in Italy. They had 234 liver transplants that underwent the same protocol. They found that the perfusion fluid cultures were positive in about 13%. And actually quite a high percentage were high-risk pathogens, but despite this, they had only 4 recipients who developed PRF-related infection. They were quite severe infections. These people have very long ICU stays and a higher 1-year mortality. Everyone received perioperative antibiotic prophylaxis, very similar to our unit for tazobactam for 24 to 48 hours. And all of the organisms that were cultured were at least partially covered. Some were suboptimal, though, about 60%, but there was some expected activity. And only one patient in this retrospective study had actually received preemptive therapy. So I guess it's, the authors concluded that while these infections are still, excuse me, quite rare, with adequate prophylaxis, they are severe if they occur. In terms of normothermic machine perfusion, this was also the first, and as far as I know, only case report in the literature of a 45-year-old man who received DBD graft for alcohol-related liver disease. He deteriorated very rapidly postoperatively, had a fever, lactic acidosis, multi-organ failure. First, they thought he had primary non-function. However, an ESBL-producing E. coli was cultured from both the perfusion fluid that was collected just prior to implantation and from blood cultures from this patient. The organism was resistant to piperacillin tazobactam, which was part of the usual protocol for prophylaxis, and the patient responded to meropenem and recovered. There have been a number of studies in addition to what Pram showed earlier that have been conducted a little more systematically, both retrospective and both from Holland. The first one looked at liver machine perfusion. They had 59 patients or donor livers that went on HOPE, 31 with normothermic machine perfusion, and all of them had a period of static cold storage before either perfusion modality. Similar to previous studies, the fluid that was collected just after static cold storage was positive in about 52% of cases. In this figure with the many little petri dishes that make me smile, after HOPE, they didn't have any positive perfusion fluid cultures or infection in recipients. However, after normothermic machine perfusion, they did have one recipient infection matching E. coli isolated from the static cold storage solution. And that was confirmed to be identical by whole genome sequencing. Would you believe it? It was the one patient where they forgot to collect some fluid after normothermic machine perfusion. But presumably, given that whole genome sequencing confirmed it was the same organism, it made its way right through the perfusion phase as well. Otherwise, they had no other positive perfusion fluid cultures. In this study, they looked at deceased kidney donors. 73 of these had hypothermic machine perfusion, and 29% of cultures were positive. Only 26 had normothermic machine perfusion, and only 2 of these perfusates were culture positive. The picture on the right shows you the distribution of the sorts of organisms that were cultured following collection at the end of the hypothermic machine perfusion. Predominantly, it was low-risk organisms. There were 5 isolates that could be potentially pathogenic, for example, Enterobacter cloacae, Proteus, Enterococcus faecium as examples. However, they had no infection-related complications in any of the recipients. So while we know very little about the true clinical impact of preservation fluid contamination, we know even less at this stage about the contamination of perfusion fluids. We've got some anecdotal data that would suggest that PRF contamination may cause severe systemic infections. However, the epidemiology and the impact still remain pretty poorly defined. And we've got an evidence base that's really limited to some case reports and small studies. We really need further research, really in both settings, preferably RCTs, and certainly with machine perfusion and perfusion fluid contamination is likely to become more and more relevant as machine perfusion starts to replace static cold storage. Thank you.
Thanks very much again to all of our very dynamic people for agreeing to come along to our conference. Lana, can I ask you, while I'm standing here, how would you design a trial, an RCT, to look at perfusion fluid related infection?
Okay. So
You can
it's a really interesting question, and actually some experts in the field have said that we're desperately in need of a trial, and very prominent researcher from Switzerland has already written a nice little commentary on that. But I think from a microbiological perspective, it's really important that we're comparing like with like. So we need to be collecting at a defined period of time because the organ journey can have various contamination points, and so if we're not collecting at the same time, obviously you don't know even across studies whether the same issues will arise. Same fluid, I would be using automated blood culture systems. I think probably at this point with diffusion fluid contamination, we know so little about it that probably some more descriptive and observational data is a good idea to help inform a study. And I would be focusing on an RCT for preservation fluid contamination because it is still the standard of care in many centres around the world and if you're doing relevant information. I think, just before implantation is probably the most clinically relevant to what will happen to the patient, although it might be considered to be done at multiple points throughout the organ journey. And then careful microbiologic sampling of the recipient, blood cultures, urine cultures, clinical monitoring of the recipient. I think there needs to be a standardized, we need to see what the impact is initially, but I think there could be a potential for the higher risk organisms with the defined antibiotic and duration. But there should also be some effort made to see whether it makes any difference at all rather than jumping on the antibiotics.
I'd like to ask a question as well, and that's directed to Prof. Fraser. In terms of mechanical heart implantation, there must be some extra special considerations for potential infections and treatments. Would you mind just making a comment on that?
Sure. First thing, if you're going to do the randomized control trial, come and take some samples from the sheet. Different bugs, but we do it absolutely sterile, so there's everything done the same. So if there's any value, you can take whatever solution. So the biggest problem with mechanical support at the moment are the cannulae and the infection risk. You have a transplant, you get some drains, day 2 or day 3, the drains are gone, and you're kind of the biggest part of your innate immune system is your skin. Still mechanical devices, whether it's LVADs, RVADs, or total artificial heart, still got a cable coming out. So we've done a whole pile of work in biofilm on that work, Dacron grafts, wraps on it as well. I think the aim, and I know Daniel's working on it now, and we're doing some stuff, is transcutaneous energy transfer, so TET. So your iPhone can sit on the desk and get charged without a wire. And there's a lot of work going on at the moment. You have a coil inside your skin, a coil outside your skin, and it transfers energy with an intact skin system. It's a good question. I just finished one paper this morning on ECMO. What is an ECMO infection? We know that patients who are this sick are all inflamed to hell. And then we take your activated prime neutrophils and bloods. We then put it through a hyperoxic environment on a naked, non-endothelialized, massive surface area, and they get an inflammatory response. Who would have thought? There's no definition what's a catheter-related infection in ECMO. There's no global definition. The use of ECMO has gone up by over 1,000% since COVID, and they all get infected, but we don't know. Induration at the site, don't know. Pus at the site, don't know. Raised white cell count, CRP versus procalcitonin, that was JAMA paper in November. It wasn't ECMO patients. So there's so much we don't know, but we definitely know that you can get an anergy in the white cells with these devices, and there's a whole pile of cytokinemia. But I think the way forwards when mechanical support, long-term mechanical support, has to be with an intact skin. It's not there yet, but there's a huge amount of work to do that. And I think once that's doable, you don't need immunocompromised. It's titanium. So if you can close the skin and not need immunocompromised, it's pretty good.
One from online, because I appreciate our online audience. Is there any role of quantitative culture in this preservation fluid, and is it responsible for making decisions in preemptive therapy? Was Dr. Gupta's question, probably for you, Lana. Again, she sat back down. Sorry, Dr. Gupta, we'll get her back up on the stage.
Yeah, look, that's a good question. I guess in terms of diagnostic labs, really the only place where we do quantitative culture truly is in urines. Everything else is semi-quantitative. And it's very tricky if you're using something like an automated blood culture system, because you can put in a defined amount of fluid, but I don't know that I don't think we can report it that way per se. I think the tricky thing is we don't know what the contamination with certain organisms means, full stop, let alone the quantity of it. The role where it might be helpful is, I suppose, if it's in, less of it there, you might be more likely to write it off as a contaminant. But we've been doing that on the basis of the actual organism identification as well in a lot of the studies.